Today I'm going to be talking about something that is vitally important to managing the burn patient and something that I feel really quite strongly about, and that's procedural analgesia around dressing changes for burns with a focus actually only on ketamine. Pain is a large topic. There's lots of different components, and we will do many more talks on pain. But today I'm going to focus on ketamine specifically. Just to start with the mechanisms of pain. Pain comes from stimulation of the skin nociceptors that respond to things like heat, mechanical distortion, and then chemical stimulus. For example, exogenous as in a chemical burn, but as well as endogenous chemical stimuli, which are basically your inflammatory mediators. The nerve endings within the burn that are entirely destroyed will, of course, not transmit pain, and that's one of the classic diagnoses of a full thickness burn is lack of pain sensation. But there will still be a number of nerve endings that are undamaged, lying in the base of a more partial thickness burn, but exposed, and they will generate pain throughout the time and course of treatment until the burn is healed, and then through other mechanisms, often for an ongoing period of time. And these processes are complicated by the emergence of both primary and secondary hyperalgesia. What are those components? The primary hyperalgesia is the release of inflammatory mediators that sensitize the active nociceptors at the site of injury. And it's the wound and the immediately adjacent skin become sensitive to the mechanical stimuli, typically that we are doing during a burn wound dressing change. Touching, washing the wound, maybe some superficial debridements. And then sometimes, depending on what topical agent you're actually dressing with, that can be a stimulus as well. Secondary hyperalgesia is a continuous or repeated peripheral stimulation of those afferent nerve fibers that leads to increased sensitivity in the surrounding unburnt areas. And that's mediated by the spinal cord, and it's exacerbated by the mechanical stimulation. And that, of course, occurs as a result of frequent dressing changes, particularly if you've been under-analgesed for those dressing changes. The types of pain that we look at treating in burns is procedural pain, which is the short to medium duration, sometimes high intensity, that occurs during and after the wound cleaning, can also be considered part of skin grafting, and of course occupational and physical therapy. And that's going to be the focus of today's talk. But the other components we will touch on in other lectures include resting pain and breakthrough pain. Now, ketamine is a drug that causes dissociative anesthesia through use-dependent blockade of the NMDA receptor. And there's 4 components to that dissociative anesthesia. First is hypnosis, which includes the psychotomimetic effects. And then at increasing concentrations, your sedative and unconsciousness sort of effects. The important part is that it provides very intense analgesia, and then other components are increased sympathetic activity, and very importantly, a part of ketamine is the maintenance of airway tone and respiration of the patient. So in fact, it's very unlikely, although it can happen, but very unlikely cause loss of your airway or apnea. Some of the problems with ketamine is that it's unpredictable, and each person reacts in a variable way to ketamine. And of course, the other problem is tachyphylaxis, which is defined as the progressively diminished response to a drug at a certain dose, following repeated exposure and requiring increasing dosages to achieve the desired effect on subsequent administration. And the tachyphylaxis is also very variable. Some patients experience it quite significantly. After one dressing change, they need increasing doses. Other patients can sit at the same dose for weeks at a time. And this is really key, this concept of tachyphylaxis, to understanding the Peter-Maritzburg protocol for using ketamine and dressing changes. Also, an important part of our protocol is assessing the adequacy of the analgesia. You can't just give one dose and walk away. Because of that unpredictability of the tachyphylaxis, you need to evaluate your patient at the time of dressing. There's many different ways to evaluate pain. I like the FLAC scale because it looks complicated, but actually it's fairly straightforward, and you can use it in small children. You wouldn't typically use it in adults, but it makes sense to use it in adults as well. And you can really focus on doing each component, but if you understand what we're looking at, you get quite good at sort of eyeballing or assessing the patient. And you're looking at the components: face, legs, activity, cry, and consolability. And you can see there, looking at those components, if you have a patient who's in a constant frown or a clenching jaw, kicking, drawing up their legs, they're arched, they're jerking, they're crying, screaming, impossible to console, that patient very clearly has pain. And the more components of that column they have, the bigger their pain. You cannot carry on with a procedure with a patient in that condition. To the FLAC 0, where you've got no expression, normal or relaxed position, the patient's lying quietly and moves easily, they're not crying, even though they may be awake, and the patient is content and relaxed. And then, of course, 1 is in the middle. And that's quite easy to use to visualize a patient undergoing a dressing change. So here I wanted to demonstrate a patient who's had a dose of ketamine for a dressing change. Now, the dressing change you'll see starts with a wash of the patient. This should happen for every dressing change. I'm washing the burn wound and the adjacent skin, and it's quite a firm wash. And I'd like you to evaluate, using that FLAC score we've just looked at, whether or not you think that patient is in pain or not. And I'm using heavy scrub soap and water on a big swab to clean the patient. I'll show you again. You can't hear anything, but you can see the patient isn't screaming. She looks comfortable. She's lying there. She's not withdrawing or pulling in her legs. So I would say this patient is pain-free. And this is the desired condition of the patient when you do a dressing change. And in general, if the patient is not looking like this, you should be thinking about giving a second dose. So to go through our protocol, the starting dose of ketamine, if given orally, is 5 milligrams per kg, and it takes 30 minutes to work. And you must wait the 30 minutes. It's important that it doesn't happen at the same time. The child gets given the analgesia dose to drink, and then everybody starts ripping off the dressings. It is not going to work, and it leads to problems, which I'm going to talk about as we get through this lecture. You've got to wait the time. Intramuscular ketamine is also 5 milligrams per kg, but it works much quicker, usually 5 to 10 minutes. You can give it in the arm or the thigh or the bum. I generally give it in the arm because it tends to work quicker. And then you can give ketamine IVI as well. These are then in 1 milligram per kg titrations. It's quite a quick onset, usually about 1 to 2 minutes. And that's why I've put the word titrations there, because often you'll need to give another dose because the offset is quite quick. And there it is written in the PMB Way protocol. So it's 5 milligrams per kg per os for both children and adults as a starting dose. Generally, we mix it with panado syrup for the kids, and some juice or something would be good as well. Even for the adults, the ketamine tastes a bit gross. And it's not a special ketamine. It's literally the IV ketamine or the IM ketamine that's given to them per os. It should be mixed together with 0.25 milligrams per kg of midazolam. And in an adult, you'll round it up. And a small little old lady, you'd give 2.5 milligrams, whereas the average young adult male, you'd give 5 milligrams of midazolam. And that is just to manage the dissociative part of the ketamine. It's a once-off dose that never gets repeated. And in my experience, a lot of the problems that come with procedural analgesia is often by an incorrect, so too high, or repeated dose of midazolam being given. So that is a standard dose given together with the ketamine at the very first dose of analgesia. Oh, no, I've put the picture there wrong. But that is a picture of a kid who is clearly in pain. And if the child is in pain during the dressing change, you need to stop what you're doing, step away, and give a top-up dose of analgesia or an additional dose of ketamine only. Do not hold the child down. Do not carry on with the dressing change. Stop what you're doing and give the second dose. What is the second dose? Well, in children, we're giving half the previous dose that was given orally. We now give intramuscularly. Remember, the oral dose takes long to work, so if you repeat an oral dose, the one dose is wearing off when the other one is wearing on. So that's why it makes more sense to give something with a quicker onset. So the second dose is IMR. Adults, sometimes they're getting quite significant doses orally, and it's just too large a volume to give that injection IMR. So adults generally will be 100 milligrams ketamine stat as a top-up dose. Again, you might be in the problem that you've got inadequate analgesia to proceed, and you can repeat the additional dose one more time. And you're going to give half the previous dose that was given IMR in a kid, and for an adult, you will give another 100 milligrams IMR. And this is really one of the key components of this protocol. If the first dose was inadequate today and you were required to give top-up doses, that initial 5 milligram per kg dose will still be inadequate at the next dressing change. So you must increase the dose for the next procedure. The final dose of ketamine given today must be rewritten as the script for the following dressing change. Really, it's terrible to leave that inadequate dose, and you land up in a vicious cycle of a patient every dressing change being under-analgesed and getting top-ups, and that is not a place where you want to be. So to give you an example, if we gave a child 100 milligrams of ketamine per os, we then had to give a top-up of 50 milligrams IMR, which still didn't work, and then a second additional dose of 25 milligrams IMR. I'm going to cross out the 100 milligrams, and I'm going to re-script oral ketamine at 175 milligrams for the next dressing change. The 100 plus the 50 plus the 25. My midazolam dose will remain exactly the same, at 0.25 milligrams per kg per os. And really, I want to emphasize, you have to change the script for the next dressing. Some additional points: ketamine doesn't really work well on a full stomach. So if they've had breakfast or the NG feeds haven't been stopped, it can be a reason for failure of the ketamine to work effectively. So feeds should be stopped 2 hours prior to dressing changes. It's just not practical to stop it for 6 hours. And patients land up being starved for inordinate amounts of time repeatedly, and that lands up with more complications than not. Also, more modern anesthesia guidelines have really significantly shortened the nil per os period of time before you receive a drug like ketamine. So 2 hours is sufficient. Another additional point: if you've given the second top-up dose of ketamine and the child is still, or the adult is still not adequately analgesed, call for help. Because you might be in a place of wind up for the patient. This is where the central nervous system has adapted adversely to repetitive pain impulses after prolonged stimulation of those nociceptors. And it causes a profound effect to the nervous system architecture and alters the processing and the response to pain. So repeat or high intensity stimulus become progressively increasingly excitatory even after the stimulus is removed. This process, this concept is called central sensitization or wind-up phenomenon, and leads to non-responsive or chronic and intractable pain. And in the moment of the dressing change, really a hysterical and screaming patient. And that wind-up phenomenon has two components. One is the hyperalgesia, which means less and less stimulation is required to initiate pain. And then allodynia, which means that nerve fibers that are normally carrying non-painful stimuli are now recruited and become part of the pain transmission process. So that means things that normally should not be causing pain for this patient are being interpreted by the patient as pain. And when you've got a patient needing a dressing change who has this wind-up phenomenon, often we've had to give them drugs such as propofol to completely knock them out and get on top of their pain. So call for help if you've needed 2 additional doses, because something's gone wrong and we need to address that. Then further, a doctor must be present in the ward during the dressing changes to facilitate additional doses given, because these are not given by the nurses. You can't give the ketamine dose and then walk away. You also need to be there to manage complications. And while ketamine is rather a safe drug, there can be problems, most notably emergence reactions, a tachycardia, nystagmus, depressed cough reflex, and probably the most common is increased salivation, maybe muscle spasms, and then respiratory depression and apnea, generally only occurring with very large doses or rapid infusions, but these complications can happen and you need to be there at the bedside. The other consideration to be made in a patient who really has massively high requirements of ketamine for the changes or every time repeated doses, and it's not a problem of failure to increase the starting dose each time, but really the patient is genuinely needing massive doses. You need to speak to a senior, and there's some considerations. Maybe their pain is not controlled from a background perspective, and we need to increase their background analgesia. We need to consider neuropathic pain and adding medication to address that. And we need to consider that anxiety and or depression and or PTSD might be a problem, and we need to address those components. Just a couple of words on the administration of ketamine and which route we're giving it. In general, the wards we're giving oral ketamine to avoid the repeated IMR doses, which is rather unpleasant, and itself sets up anxiety, certainly in kids, and we've got the time to plan and do the dressing change. In the clinic, we don't have the time, and generally we're giving IMR ketamine. It's a quicker onset and offset, just to say, do not give it to an adult patient in the clinic. They take much longer to recover, and then they're not able to go with their own transport home. Children are a lot easier to manage, so we're giving IMR to the kids in the clinic. And IVR can be useful, but generally that would be in an ICU or a high care setting, or some particular patients, exceptional circumstances where we've had problems with oral or IMR, but that will generally be a decision taken by somebody more senior. And then to be very aware that ketamine comes in 3 different concentrations. There's 10 milligrams per mol, 50 milligrams per mol, and 100 milligrams per mol. You need to pay attention to what concentration you're drawing up, and you should never, ever prescribe or write down ketamine as a dose in milliliters, because if you're saying 10 moles and you've got a 10 milligram solution, your 100 milligram dose will be fine, but it's definitely not going to be fine if you're drawing up 10 moles of 100 milligram per mole solution, and you can land up in some deep trouble. So generally, the more concentrated dose, the 100 milligrams per mole, is best for IMR. You can use it for everything else, but it obviously gets more complicated in smaller kids with smaller doses. And then you may need the 10 milligram per mole, which is also good for IVI administration. And then 50 milligrams per mole is often good for oral administration. Just to end off by reminding you of your starting doses, it's 5 milligrams per kg, except in the case of IV, which is 1. Remember your longer onsets of action in the oral, so you need to wait the time and not start prematurely. And really to focus on giving the additional dose as needed. You must be there. You must evaluate the patient's degree of pain, stop the process, and give the additional doses. And in children, it's obviously dependent on how much they weigh. Adults is a little bit easier, and it's a stock standard 100 milligrams IMR as a top-up, which you can repeat 1 more time, and then you call for help. And if the 1 dose didn't work today, it's definitely not going to work next time. So you need to change that script. So this is the picture